So for our final lecture this morning, it's been an amazing session, and this next lecture is going to be amazing. We have another giant in the field. Connie L is a professor of global health medicine and epidemiology at University of Washington, and a true expert in research and prevention, both of STIs and HIV, and today is going to be talking to us about prevention in syphilis. So please come on up, Connie. I really welcome you being here, and we'll hear about DoxyPrep today. Thanks.
Thank you. It's really fun to be at this conference. I love the interactiveness, and I'm sure we'll have some good Q&A. So today, just in this talk, I'm going to really focus more on the evidence to make sure people know what we've learned and some early insights from implementation. And then at the breakout session, I'm going to talk more about the how of implementation, and my colleague, Dr. Hyman Scott from San Francisco, will share their experience where they've had several thousand people start DoxyPrep. So it's a very dynamic field. So here's my disclosures. And for the DoxyPrep study in particular, we did have drug provided by Maine Pharma and laboratory support from Cepheid and Hologic. So my hope is that after this talk, you'll have a better understanding of how and when to utilize DoxyPrep, and with the goal to reduce incident bacterial STIs, and a practical approach to prescribing, and also to be cognizant of the current unanswered questions. This is very new, and we're all trying to be aware and not underestimate the uncertainties, but also to move forward. So first, I'll talk about the data that support the use of doxycycline for post-exposure prophylaxis for STI prevention. Talk about antimicrobial resistance, because I think that's on many people's minds. Talk about the recently released CDC draft guidelines, as well as some of the local guidelines, and then highlight early implementation experience in San Francisco. So you saw the slide on the right from Dr. Meredith Clement in her syphilis talk, and just to say that these numbers have been going up for now close to 8 years. So it's not just like a aberration post-COVID phenomenon, that we have this approach, and I see bags around with the CDC logo about how we're trying to do test, treat, and talk. But we've been doing that for a while, and we haven't made great progress. So I think it's time to take stock and ask, what can we do better? On the left are the WHO estimates, and as you can imagine, because there's really very limited STI diagnostic testing in many parts of the world, that this is a very large underestimate, that many STI diagnoses are based on syndromic management, which is very imperfect. So keep in mind, we're talking about this not just as a US phenomenon, but global. And you've seen the slide in the bottom from Dr. Clement, and I just want people to be aware that when you ask the question, which seems like a simple question, about how much of gonorrhea and chlamydia is in men who have sex with men, we don't really capture sexual orientation and gender identity very well, except for MSM, except for the Sun collaboration, which has about 10 STI clinics. And if you can read in the kind of maroon color in the upper two slides, it shows by city and age, kind of the breakdown of these diagnoses. And really in maroon are men who have sex with men. And given that they're a much smaller proportion of the population, I think it is fair to conclude that MSM are disproportionately impacted for gonorrhea, chlamydia, and syphilis. So first, I just want to highlight something that may be self-evident, but I think as we think about counseling with people, we should be very specific. All the evidence is for doxycycline. There really, when we designed our trial, we thought about other antibiotics, and there really is not another antibiotic ticks all these boxes, that is based on a long history, safe, well-tolerated, and generically available, inexpensive, that has activity against all 3 of the bacterial STIs, chlamydia, syphilis, gonorrhea. We do know that there is intermediate level resistance to gonorrhea in about 1/5 to 1/4 of U.S. isolates, but we don't use it for treatment, so we're not sure that we're really going to do harm by using it for prevention. But we also don't know, and this is true for many prevention interventions, including HIV PrEP, we really didn't know how much you need to prevent something. So you sometimes have to just be clear that treatment and prevention are different, and we don't have as much, it's much harder to get the data on what you need to prevent an infection. So I'm going to summarize 3 recent clinical trials in which the question was asked, could you take doxycycline? First of all, would people take it well enough to be able to prevent bacterial STIs? And then what did we learn in the process of these trials about antimicrobial resistance, both in STIs and then other bacteria? So the design of the trial that I co-led with my colleague Annie Luchtmeyer from UC San Francisco, we designed as an open label randomized trial. And you might say, well, why open label? Why not placebo controlled? And partly because we wanted to understand the impact both biologically and behaviorally. We wanted people to know that they were in the active arm, that they were taking DoxyPEP, so that if they changed their sexual behavior, number of partners, condom use, that we would observe an effect in the context of the kind of behavior change that would happen in the real world. We did a 2-to-1 randomization because first of all, we were afraid when we designed this study that people wouldn't be willing to be randomized. You sort of have all these lists of things that you worry about in the beginning and then at the end. In the beginning, it was, would people do it? Would they even sign up for a clinical trial? Would they be willing to do this once per day maximum after condomless sexual contact? And would they persist with it? We designed our trial to ask the question about, does DoxyPEP work both among MSM and trans women living with HIV and those on PrEP? And the data suggest from a lot of epi studies that the STI incidence is higher in PrEP users, but we felt it was also a relevant question for MSM and trans women living with HIV. So we had planned to enroll about 780 participants and did STI testing per the protocol in San Francisco and Seattle clinics, which was every 3 months. We enrolled persons who were assigned male sex at birth and had condomless sex with at least 1 male in the past 12 months and had had an STI in the past 12 months. And then we had 1 interim look for efficacy or futility, and that's when we were told to stop the control arm. And first I just want to highlight, because I think it's always important to be thinking about the populations in these trials and how well does it sort of line up with the populations you're seeing. These were largely men in their late 30s in both cohorts. At the time, I'm showing you the data from when the Data Safety Monitoring Board reviewed the trial with 500 participants. And this shows you the demographics and the fact that over 80% were having sex with male partners only, and we had a harder time recruiting trans women. Most, by inclusion criteria, they had to have an STI. About 2/3 had had gonorrhea, about a little over half had had chlamydia, and about 20% had had syphilis. These were highly sexually active men. Median number of partners in the past 3 months was 9, and about 90% reported only condomless sex. So when we talk about the results, it's also important to realize that we looked and didn't see any change in sexual behavior. They had already made decisions around not using condoms. And what we found, this shows it by cohort, the persons living with HIV on the right and the PrEP cohort on the left. In blue is gonorrhea, orange is chlamydia, and syphilis is in green. And one of the reasons why we were stopped early is that when we designed the trial, we expected about 10% per quarter to have an STI in the control arm. We saw 3 times that. So STI rates, at least in this population, were quite high. The results were quite consistent between the 2 cohorts, with about a 2/3 reduction in STI incidence on a quarterly basis. And as you can see, we didn't see a lot of syphilis. There was a median of 9 months of follow-up, and we did see a reduction, and it was significant, but we had many fewer syphilis cases. If you break it down further, still by cohort, but now by anatomic site, it's a little bit hard to see, I can imagine, but there's a very thin line for both chlamydia and gonorrhea about urethral infections. These were mainly rectal and pharyngeal infections. And again, the data were consistent with a significant reduction, about 55% for gonorrhea and close to about 80% for chlamydia and early syphilis. And that was pretty much in line with what other trials have found, and I'll show you those data soon. So if you look at a Kaplan-Meier curve and time to event, another way to look at it, basically the observation was seen that this was working early in the trial, and it persisted, and the lines really did not converge. So very strong effect. And I think one of the things I've learned in the clinical trials I've done is that it's really important to try to capture the voices of the users, and the way to best do that is through qualitative research. We enrolled 44 participants and tried to oversample racial and ethnic minorities, as well as had almost half living with HIV. And what came through as the overarching themes, and this was presented at IAS earlier this year, is that it gave people peace of mind and improved intimacy and sexual pleasure, and it changed their mindset, at least in this qualitative subset, more than their actual behavior. And they felt that they were empowered, being more proactive, responsible about their own health and the health of their community. And some, but not all, talked about the risk of antimicrobial resistance, but felt that that was not a barrier to use. I will mention another study that was presented this past year at CROI and focus on the top bar. It was a factorial design in France by Jean-Michel Molina, where they had very similar enrollment criteria, and they randomized MSM on PrEP. This did not include persons living with HIV, to get doxy-PEP or no PEP, and then Bexsero meningococcal B vaccine or no vaccine. And basically, we're designed the study in a very similar way. You'll hear more about their meningococcal B vaccine results at CROI. They had to reanalyze the data, so I'm not going to touch on the Min-B because you'll hear more soon, but really just focus on doxy-PEP. And what they reported, and this has not changed when they reanalyzed the data, is they found an 84% reduction in time to first chlamydia or syphilis, and again, had about 9 months of follow-up at the time that their DSMB recommended they stop. So almost identical results in their PrEP cohort as ours, and about a 50% reduction in time to first gonococcal infections. So good news, too, it's always better if you're going to have a positive result that you're not the only one and that the results are consistent. So 2 very strong studies showing efficacy in men who have sex with men and trans women. And then, unfortunately, as Meredith mentioned, there was a study in cisgender women in Kenya that some of my colleagues did, and this was one-to-one randomization, also open label, same dose, same instructions, in about 450 women taking HIV PrEP. And they followed them quarterly for 12 months in Western Kenya. And it was really disappointing. Like first, they had a flat result, and I'll show you those data. So the first question people say is, well, maybe there weren't enough endpoints. They had plenty of endpoints, most of which were chlamydia, almost 80%. And the data on the right show the time to the first incident STI and the time to first incident chlamydia. They powered the trial to look at an effect on chlamydia, and it was flat. Even when they took out women who had stopped doxypep due to pregnancy. So there was really no signal. And this was on the left in the context of very high self-reported adherence, where quarterly surveys, a follow-back calendar, and weekly SMS suggested that women said they were taking 70 to 80% of doses. So, this is a bit of a deja vu for people who followed the field on the early trials with HIV PrEP in Africa, that there was clearly over-reporting, at least as best we can tell at this point, with hair to measure doxycycline exposure. Almost half had no doxycycline detected in hair. If there's time, we can talk about why there's this disparity. But I want to underscore that this is in the context, STI testing is not done in Africa. And so very different trial population than what we had enrolled for the MSM studies, where they had to have had an STI in the past 12 months. So maybe their motivation was less. They're also, most of them newly on HIV PrEP, so maybe trying to blend HIV PrEP with post-exposure dosing was harder than we thought. This needs to be unpacked, but at this point it suggests that adherence was a major factor. And one other key line of evidence came from a PK study that was presented at CROI in this year, where Rick Halen from the CDC did a single dose of doxycycline 200 milligrams and looked at plasma in the little triangles, rectal secretions, and vaginal secretions, and tried to look at the MICs for each of for chlamydia, syphilis, and gonorrhea, and showed that with this dose, not only were you above the MICs, but you were above them by 11 to 20-fold. And they stayed above it for chlamydia, not so high compared to the MICs for gonorrhea, and they stayed above it for a shorter time. But basically, it suggests that this dose of 200 milligrams should be very effective in women as well as in men, and you might predict higher efficacy against chlamydia and syphilis than gonorrhea. So just putting it all together, I didn't go into details, but there had been a smaller study. The first evidence came from the Ibergay study, and these are very consistent results. The only differences are that in the second French study, they showed efficacy against gonorrhea as well as syphilis and chlamydia. The rates of infections were high in all these, in the standard of care arms in all these studies, and then the flat results in cisgender women. There's no reason, I think, to suspect it wouldn't work in cisgender women, and there will be another study undertaken in the Adolescent Trials Network to provide more data from young women in the US, so stay tuned. It was also very safe and very well tolerated. We had really few adverse events, either by symptoms or laboratory monitoring, very few discontinuations. And because of the literature that suggests that if you impact the microbiome with doxycycline, will there be an effect on weight gain? We found no change in the doxypep study. So in general, a really well-tolerated drug. And in general, people were taking about 4 to 6 doses per month for these, in these event-driven trials. So what we've learned is it works. It works well, and when you think back to yesterday's lecture by Steve Greenspan on the the cardiovascular trials and number needed to treat, when you're hearing 40, 200, this is a relatively small number of people needed to treat with doxycycline PEP to prevent an STI, and we'll come back to that. So the key question, and that I think gives us the most pause, is just what about the trade-offs? What about antimicrobial resistance? And I think what we've learned, we embedded in the DoxyPEP study nasopharyngeal cultures to look for Staph aureus, and we found that almost half of men were colonized, men and trans women were colonized with Staph aureus, that those in the DoxyPEP arm had a reduction in colonization, about a 14% reduction, and a slight increase in doxy resistance in those who remained colonized compared to their baseline results. MRSA was low, 6%, and we didn't see any increase in doxy. So this is, again, just to remind you, a median of 9 months of use. We would like to have longer-term data, and we'll try to get that. And then for gonorrhea, we found, first of all, it's a wily bug. It's harder to culture than you might think. And for those who we could get in for cultures before they were treated, we found a slight increase in tetracycline resistance in those who had gonorrhea after enrollment in the DoxyPEP arm compared to standard of care. Similar data were seen in the DoxyVac study. So we don't have any evidence that DoxyPEP induced resistance, but it may work less well against those who are exposed to a tetracycline-resistant strain. And does that matter? We don't think it'll impact treatment because we don't use doxy or tetracycline for treatment. There is at least some discussion about if you increase tetracycline or doxy resistance, could you stimulate resistance to other antibiotic classes? Honestly, the data are limited and mixed, but it's something to monitor. And will we lose the efficacy against gonorrhea over time? Just a word of, to interpret this, that in France, the resistance is at least about 2 times higher in terms of tetracycline resistance in GC, and they still saw a 50% reduction. So far, no evidence that's happening, but we'll need more experience to know that. And there are trade-offs. I think sometimes in people's trying to think about this in their minds, they're thinking about it's DoxyPEP versus no antibiotics. But these were highly antibiotic-exposed persons because of their STI history. And because of the reduction in gonorrhea, we also reduced ceftriaxone use by 50%. So there are trade-offs. What about impact on other STIs if this is adopted widely? Well, first of all, there has never been any evidence that chlamydia becomes resistant to the tetracycline class. There are a few studies of a different chlamydia species, chlamydia suis, in pigs where it can happen, but no evidence in humans in spite of using doxy for a long time. Similarly, we have not seen this in syphilis. And so these are questions that one can mull over, but I think the evidence from a long period of use of doxycycline is that we're not going to be stimulating lots of resistance. And then lastly, M. genitalium, doxy is not very effective on its own, and many places use a 2-step therapy for M. gen, where you might lower the quantity of M. gen with doxy and then follow it with fluoroquinolones. But honestly, we don't have strong evidence that this is a problem. And in fact, the DoxyVac study found a reduction in M. gen. So the data will continue to evolve. What about antimicrobial resistance surveillance? And I think that it's really important, we'll talk more about this in our breakout groups, to be reminded of how much doxycycline is in our food sources for those who eat poultry in particular. And that one of the most common categories of antimicrobial resistance genes in human studies is doxycycline. So it's really, I think, you have to go in with your eyes wide open that we're not bringing in exposure to an antibiotic that people haven't seen in lots of other cases and through other sources. We need better surveillance systems, and we've been talking with CDC, and I think there will be efforts to try to do more in terms of surveillance. That about 10 cities are part of a surveillance network called SURGE that does antimicrobial resistance. We'd like that to be expanded. Very hard to monitor, but in our efforts in the Doxy-PEP study, we did not see any evidence of resistance in chlamydia or syphilis. And then other bacteria we care about, so-called bystander bacteria, are staph and strep. And I think we looked at staph, we plan to look at strep. We have looked at the gut microbiome and really didn't see any significant concerns. So good concerns to raise, but so far the early evidence is reassuring. So what about shifting to implementation? That San Francisco was the first to come out with guidelines after the Doxy-PEP and Doxy-VAC results were presented. They came out in November of last year or October, and they recommended it somewhat broadly. The first one is to the people who have the same eligibility as we enrolled in the trial, had a bacterial STI in the past year, and report condomless sex with at least one male or trans female partner. But they also encourage shared decision-making, and there may be others who want Doxy-PEP who don't narrowly fit into that criteria, and we should be honoring their respects and discussing what we know and don't know with them. And they did not recommend it for individuals whose only exposure is receptive vaginal sex. Again, come this afternoon if I guess I'm supposed to say if you signed up, but the data, and you'll hear more about this at CROI, San Francisco has by far the most data on implementing Doxy-PEP, and it's encouraging, both in terms of who's interested in it at their sexual health clinic at San Francisco City Clinic and at the San Francisco AIDS Foundation Struck Clinic, where they have over 2,000 people on Doxy-PEP as of this summer. So far, they're not seeing disparities by race, ethnicity, or age. The frequency of use is similar, and I think what's coming from the San Francisco City Clinic is that people are using it somewhat selectively, not after all encounters, but most. And exciting data from the San Francisco AIDS Foundation that we're beginning to get some suggestion that there's a reduction in STIs in the real world. So CDC did issue guidelines in October, and these were for public comment. They gave it an A1 recommendation for MSM and trans women with a history of STI in the past 12 months, and did not make a recommendation for cis women, cisgender heterosexual men, and other populations. Again, they recommend screening first, counseling on risk reduction, and really talking about what's known and not known so that a person is making informed decisions, and to dispense as much as needed to, at least for that initial trial period. Many people are dispensing about 30 tablets. And I think the last part of this is just to whom and like how do you balance number needed to treat and efficiency with equity. There was an excellent paper that came out in CID 2023 that suggested you could do it just based on PrEP users or persons living with HIV. You'll treat more in that context, and that probably the more selective way to do this would be based on recent STIs, and this just shows you in blue the number treated, and in orange the proportion of STIs averted. And you can see there you get more and more efficient, but you also prevent a lot fewer STIs as you go down that line. So I'll end and say that I think it's pretty clear from the EPI data that we need new STI prevention tools. The evidence is consistent and strong for doxypep efficacy in men who have sex with women and trans women, and it's strong for both those living with HIV and those on PrEP. That it's not for everyone. We're not promoting this widely. That it really, I think, at least initially, as you're trying to get experience with this, prioritize those with a history of STI, but also consider and would not refuse if someone asks for it and thinks they're at high risk for STI, needs to be discussed. It's not forever. It may be something that someone does on a yearly basis and you reassess. And it needs to be integrated into PrEP and HIV care programs and part of a sexual health package that includes vaccinations. And then to assess antimicrobial resistance, both in GC and then in the context of demonstration projects looking at staph, strep. And then lastly, and I feel quite strongly about this having been involved in one of the HIV PrEP trials, it took us a decade to really recognize the disparities in access to HIV PrEP, and we still see this in the Southeast and for women, and data at CROI last year were also showing emerging disparities in the Northeast. So we need to be mindful of the fact that this is something that we need to try to do a better job with. We should have learned from our implementation experience with HIV PrEP. Then lastly, I'll just give a lot of thanks to the people who participated in the DoxyPep study, the participants in particular, but also the investigators in our Data Safety Monitoring Board, and I look forward to the discussion.
Hello, thank you. That was just a master lecture in going over what the data are and some of the considerations we all have. There were many questions about the 24 to 72 hours and that being a little complicated, like that. Can people take, can they take their dose immediately after they have sex? Like, are there data to support that?
Yeah, I think the data from the PK study, if you sort of envision those early peaks, it peaked quite early, within 12 to 24 hours. What we've settled on is to tell people to take it sooner the better, and ideally within 24 hours. In our questionnaire, it looked like the majority of people reported taking it within 24 hours. So the longer tail is for if you forget.
Great. And we've got here in the middle and then on the left.
Thanks for your talk. Question, you mentioned the average was about 4 to 6 times a month in some of the event-driven dosing, but that in the San Francisco data, some people were taking it selectively. I guess the question is, if you encounter patients who are having a very high amount of unprotected sex daily, multiple times daily, perhaps due to commercial sex work or otherwise, what is a reasonable recommendation? Should that person be advised to take Doxy daily? I guess your comments on that.
Yeah. So there was a subset of people who, in our study, who reported taking it more like 10, the upper quartile was 10 per month. And what we tried to say, and I think some of the counseling messages could be clearer now that we've had experience with it, is take it only once a day. So count it as a day with sex or without, and then take it no more than once a day. I should mention there is a study in Canada that's pretty early on, but is looking at DoxyPep versus PrEP that'll give us the answer to the question about, for those who really are highly sexually active, is there a benefit to doing it more like daily?
And if they were to take it daily, is it like at 100 milligrams or would it still be at the 200 milligrams?
Yeah, I'm pretty sure they're using 200 milligrams, but the CDC group who did the PK study is also looking at different dosing strategies and even 100 milligrams, because I suspect 100 may be enough based on how far we overshot the MICs.
Great, because one of the questions was about people taking daily Doxy for acne at 100 and if that would be sufficient.
Yeah.
Thank you, Connie. Curious if you have observed or if you're having follow-up with research participants on the impact of RPR titers with episodic doxycycline?
Yeah, that's a big question. We did not see that they, at least in the study, there was any change. But again, there were relatively few patients with acute, early syphilis. So I think that is going to require more experience and something that we all have to pay attention to.
Hi, I'm wondering if there was any decrease in adherence appointments. When we started at the clinic I work at, and the first question he had was, do I have to come every 3 months still if I'm taking the doxypep? So I'm wondering if the data showed a decrease in patients coming back to the clinic.
In the clinical trial, they didn't, but I think that there's not a reason that they have to make in-person visits to do this. You can do e-refills. I think that if they're clear on the dosing, that you can have phone conversations too as needed. But at least in the trial, there's no evidence that over the average of 9 months of follow-up that adherence decreased.
So do you give, when you're prescribing it, do you give a refill of 30 or 60 tablets? Like how do you rate for it?
So the 30 doses, so 60, 100 milligrams.
And how many refills?
So I think this is where I think there's a variety of practices. I think it's reasonable to just not give a refill and just so that you can have a conversation to see how it's going. But I know some providers are doing refills too.
And what form of doxycycline, monohydrate or hycolate?
Yeah, hycolate's a little bit more expensive. It's what we had donated, but monohydrate should be fine and might have less GI toxicity.
And who pays for it in the real world? Do you know?
Well, the real world apparently includes with the various discounts. You can get it for about $5 a month. So it's we have not had people who had issues getting it paid for by insurance, and the cost is pretty low out of pocket.
Okay, so a few questions about women. So there aren't, despite the lack of data in women, are you using doxypep for cisgender women? If a woman came in, a cisgender woman, and asked for it, would you prescribe it? Like, what is your thinking about that?
Yeah.
And also comment on heterosexual men.
Yeah, I mean, I think that's where trying to understand their motivations and have they had STIs in the past, what's driving this. It requires maybe a longer conversation. I have not prescribed it for women yet, but I don't have that many women in my clinical practice. I think in the San Francisco City Clinic, they have had a relatively small number of women. So, I think that the current recommendations are still not to use doxycycline during pregnancy, even though that's a lot of the concerns about teeth discoloration have been put aside, but still you would have to talk to them also about pregnancy plans.
And heterosexual men?
Again, I think what we're really trying to reach are the people who have a high likelihood of having an STI in the next year. So if they come in and it'll have to be sort of thought through and discussed on a case-by-case basis. If someone has had multiple STIs and they're a heterosexual man, I think it's reasonable. It probably works. And we won't likely have studies to answer that question.
Great. And staying with cisgender women, in the study from Kenya, was there a relationship between a negative hair test and women who acquired STIs? Was that, I know that it was ecological data, but was there data that was able to trace an individual woman and her response with her actual hair level of?
They haven't done those analyses yet.
Okay, great. So if someone is allergic to doxy, they have an allergy, but it's very high risk, is there an alternate antibiotic you would consider it at this time?
No, I don't think that there's someone, I think first of all, it's relatively rare, so I don't think it'll come up that often, but I would not use azithro because of the concerns about the single point mutation and syphilis, but also it's not as efficacious against chlamydia and not recommended for gonorrhea, so I don't think there's an alternative. Right?
Okay, we've got a question on the far right.
Yeah, hi, thank you. Just any thoughts on counseling trans men and other people with ovaries who have receptive anal sex frequently about using doxypep?
Yeah, I think that if there, I think you can extrapolate that from rectal exposure that it should work. And I think that it's reasonable to prescribe it if they have other criteria that would make them eligible.
Another question, if someone has been exposed to syphilis but took doxypep as part of that encounter, would they get the usual response?
Yeah, again, this is something where we don't have a lot of data to go on. I think that people are actively discussing whether we should change our guidelines for empiric treatment for context, but I think it won't change for syphilis. So
Great.
we definitely want more information as we implement this about effects on serologies.
Great. And this is from a prescriber in Albuquerque, New Mexico, who says, when I prescribe doxypep to my patients, I ask them to agree to the following: to use it only as directed, not to self-treat, including STI symptoms, all other infections, cough, rash, sinusitis, and not to share the prescription. What other counseling do you advise?
First of all, thank you for bringing that up. I think that's one of the other concerns that people have is what happens to the doxy that isn't used. And I think we are concerned about self-treatment of STIs. There are some discussions going on, though, if it's being shared with someone who is in their sexual network who might also be at risk for STIs, maybe that's not the worst thing. But I think the other counseling messages are just to really advise people, especially in sunnier environments, about photosensitivity, and then the pill esophagitis, and to definitely take fluids and sit up for a while. And there's some great counseling sheets with graphics on the health department website and San Francisco City Clinic website.
And looking forward to maybe this will be effective in women, if this is looked at again, are there plans to also look at the potential of yeast infections or other complications for women on antibiotics?
Yeah, and they did look at that in the Kenya study, but with higher adherence.
And what did they find, do you know?
They haven't reported it yet.
Great. Well, I think we've come to the end of our questions, so
Thank
thank you so much. That was fabulous.